Good afternoon, and welcome to this webinar on vitamin D and nutritional management of patients in fracture liaison services and vitamin D status in Qatar. My name is Eric Brulé-Champagne. I'm the Capture the Fracture Coordinator at IOF, and I will be the monitor for today's session. Before introducing our speakers, Professor René Rizoli and Dr. Omar Al-Saed, I would like to inform you that all participants are automatically muted for the duration of the webinar. I would also like to encourage you to ask questions during the session by typing them into the question box of the control panel. I will voice the questions to Professor René Rizoli and Dr. Omar Al-Saed during the question and answer session planned at the end of the presentations. That being said, I'm very pleased to introduce our first speaker, Professor René Rizoli. Professor René Rizoli is an internist and endocrinologist with a subspecialty focus on metabolic bone diseases, osteoporosis, and disorders of mineral metabolism. He is Emeritus Professor of Medicine at the University Hospitals of Geneva and former head of the Service of Bone Diseases. Professor Rizoli is currently the IOF Treasurer and former Chairman of the Committee of Scientific Advisors of the International Osteoporosis Foundation. He is also the chairman of the Scientific Advisory Board of the SCO and co-chairs the Scientific Program Committee of the annual IOF SCEO Congress. Throughout his extensive career, Professor Rizoli has been involved in both basic and clinical research projects investigating pathophysiology of osteoporosis and of calcium and phosphate homeostasis disorders, the role of nutrition, calcium, protein, bisphosphonates, among other topics. He is author of more than 900 scientific articles, editor-in-chief of Calcified Tissue International and Musculoskeletal Research, and associate editor of Osteoporosis International. I will now leave the floor to Professor René Rizoli.
Thank you very much. I'm very pleased to be with you tonight, and particularly to cover this topic of vitamin D and nutrition. As you know, in the three pillars of osteoporosis management, vitamin D nutrition is one of the three, a mandatory one. First, I'd like to start by setting up the stage. And as you know, a fracture, which is the expression of osteoporosis, results from two components. The first one is a mechanical overload, which is a consequence of sarcopenia with problem in balance, muscle strength, neuromuscular impairment. And the second component is mechanical incompetence, fragility, osteoporosis, and as you know, with defect in bone mass, geometry, microstructure, and even material level properties. And then when the fracture has occurred, there is first the repair of the fracture, and then rehabilitation with the aims to restore independence, to reduce disability, and finally, on the long term, prevention of subsequent fracture. And as you know, the fracture liaison services are affecting, are controlling, trying to improve this final pathway from the fracture to the prevention of subsequent fracture. And then the idea now is so now what we are going to discuss first is the role and the influence of malnutrition, vitamin D deficiency in the first step, i.e. mechanical overload and mechanical incompetence. Next slide. This is an illustration of several studies in which the level of vitamin D was tested in patients with a recent fracture. And what you can see here, particularly on the right-hand side, a majority of these patients had a value of 25 hydroxy vitamin D. So the way to determine the status of vitamin D below 50 nanomole per liter or 20 nanogram per ml. It could be as high as 80% in the paper by Bishop Ferrari and as low as 34% in the OWL paper. But overall, we could say that more than half or even 3/4 of the patients with a hip fracture have a low vitamin D level. Next slide, please. And this is particularly true here. If you look at the the previous accommodation of this patient when they are coming from their own accommodation home or assisted living AL or nursing homes. You see here the prevalence not of low vitamin D level, but a very severe deficiency defined by a level of 30 nanomole per liter. You see here that more than 70% in those patients coming from a assisted living accommodation or nursing home have a very low vitamin D level, are very severely vitamin D deficient. Next slide. Now the issue is what could be the relationship between vitamin D and the fracture risk. And this is a recent meta-analysis looking at the association between the risk of fracture, any fracture or hip fracture, with the level of 25-hydroxy vitamin D. And on this slide, you see the risk of having a fracture for any change, any increase of 25 nanomole per liter of calcifediol in the circulation. And for any fracture, there is a reduction of 7% for any increase in 25 nanomole per liter. And regarding the hip fracture, the reduction is 20%. So this demonstrates the clear association between a low vitamin D level and the risk of a fracture. Next slide. And this is in postmenopausal osteoporosis, but the same is true in men. And you see here different fractures in relationship with quintiles of vitamin D levels. And the reference is between 50, 60, and 75 nanomole per liter. And you see that this clearly a dose-response relationship. The lower the vitamin D level, the higher the risk of fracture. And this concerns not only the hip fracture in dark green, but also any other type of fracture with the different colors. And surprisingly, when the vitamin D level is too high on the right-hand side of the slide, there is maybe some risk of a fracture. And we have no clue at the present time what is the reason, but we could speculate that a patient with a high vitamin D level feels so well that is less cautious in the daily life. Next slide, please. So if you have some bone fragility, you could expect that one of the reasons, which is a so-called mechanical weakness, is contributing to the risk of falling. And you see here the relationship between the walking speed on the left-hand side and on the muscle strength as evaluated by the repeated sit-to-stand test. And clearly here, there is a marked increase in the time to walk 8 feet and the time to complete 5 times sit-to-stand test. And this is particularly true when the level is below 50 nanomole per liter, the red line, and a little bit less convincing when the level is below 75, the green line. So this is for the occurrence of fracture. Now, next slide. The question is, what about malnutrition in those patients with a hip fracture? And this is a systematic review published 3 years ago by a group in Spain. And the prevalence of malnutrition will be obviously dependent on the type of test you're applying. In the upper part of the slide, malnutrition was evaluated either by the level of albumin, by the body mass index, by the weight loss during the months before the fracture. And irrespective of the test applied, it seems that using this clinically relevant test, that approximately 1 out of 2 patients with a hip fracture had some sign of malnutrition, 45.7%. Now, if you look more specifically to an evaluation of the nutritional status using the mini nutritional assessment, in this case, the percentage a little bit lower, and we could say that at least using the MNA, 1 out of 5 patients with a hip fracture is malnourished. Next slide. The question is, what is now the relationship between the intake of protein, which is the intake which is particularly affected in malnourished patients, and the risk of fracture. And there are several papers indicating that if you have a low protein intake, the risk of a fracture is higher. And this is true on this slide from Canada in men and in women. If you look at clearly fragility fracture or all type of fracture. And here's the limit, the threshold identified by the dashed red line. It corresponds to 0.9 gram of protein per kilogram of body weight. And you should remember that in a healthy young adult, the recommended dietary allowance is 0.8. So those patients here, the reference is somebody clearly well nourished. But if you go below this level, there's clearly a dose-response relationship with an increase in the risk of fracture. Now, the next question, next slide, please, is to try to identify what would be the mechanism. And in this cross-sectional study we performed and published several years ago, we didn't measure the rate of fracture. We didn't measure only the bone mineral density and or bone microstructure, but we calculated the bone strength in healthy postmenopausal women at the age of 65 years. And what you can see here, there is some relationship between what they eat in terms of animal protein, dairy protein, or animal non-dairy protein, and the failure load, both at the distal radius and distal tibia. So those with a low protein intake, irrespective of the source, had a lower calculated bone strength at the distal skeletal radius and tibia. Now let's move, next slide, what happens with malnutrition and vitamin D deficiency immediately after the fracture, regarding fracture repair and regarding the rehabilitation process. Next slide. Regarding fracture repair, fracture healing, we have very few data, a few preclinical, and the only one I've found which is convincing in patients is that one. So what you can see here is they collected patient after a fracture and look at the vitamin D status. And they gave to those with vitamin D deficiency some vitamin D, and the dose was 1,200 units a day. And after 4 months, they looked at who was still vitamin D deficient, maybe in terms of compliance, maybe in terms of adherence to therapy, and those who were not anymore vitamin D deficient. And what you can see in the highlighted in red, you can see that in those not anymore vitamin D deficient, the risk of having a poor union, non-union, and this was clinically determined, was 1.7%, while those still vitamin D deficient at 4 months was 9.7%, indicating that persistent vitamin D deficiency is associated with some retardation in the healing process of the fracture. And next slide, please. The question is, what about the recovery? What about the capacity of walking after the fracture? And in the upper part of the slide, you see the ability to walk after 30 days following the fracture or 60 days. And this is a % of patients capable of walking. And there are different adjustments, but if you look at the data highlighted in red, corresponding to those with a normal vitamin D status, with 50 to 75 nanomole per liter of calcified iron in the blood, corresponding to 20 to 30 nanogram per ml, you see that the risk or the chance to be capable of walking 30 days or 60 days was 3 times higher as compared with those still displaying vitamin D deficiency, here identified by a value below 30 nanomole per liter. And in this trial, at least, if you go above 75 nanomole per liter, there was no further improvement, at least in the functional aspect of walking. In terms of, back one slide, please. In terms now of who were these patients, they were from a randomized controlled trial, and this could explain that maybe they are not as sick, not as affected as in regular patients. And to support that, you see that half of those patients had a value of vitamin D below 50 nanomole per liter, and 2/3 of those patients had some risk of malnutrition. So now let's move and ask the same question, not on vitamin D, but on protein intakes. And in terms of clinical trial, I was not able to find any well-conducted trial looking at the effect of malnutrition and protein deficiency on the healing process. And what I like to show you today is this series of data obtained in rats. In rats with a normal diet and in rats with a low protein diet, reminiscent of what you can get in your patient with a hip fracture. And here the functional aspect of osseointegration was tested by an implant into the bone, and then the function was tested by measuring the strength to pull out this implant in the bone. And with a normal protein diet, you see in the dark columns, there was a certain amount of strength to be able to remove the piece of metal in the bone. While if you look now at the open bar, those are rats with a low protein diet, like in patient with a protein deficiency, you needed less strength to remove the implant, indicating that the osseointegration was worse in those animals with a low protein intake. Next slide, please. And now if you look at the function and the overall long-term outcome of this patient, it seems that the mortality is clearly dependent on the state of nutrition, with a lower mortality up to 3 years after the hip fracture, when the mortality was lower in the well-nourished as compared with those malnourished or at risk of malnutrition. Now the next slide is it possible to improve the outcome? And this is a randomized controlled trial in patients with hip fracture, and they receive 20 grams of protein per day, 5 days a week, over 6 months after the hip fracture. And they were compared to patients with a standard care. And what you can see here on the right-hand side, those with proteins supplementation, we just corrected the low protein intake. There was an increase in the hormone IGF-1, which is a good reflection of the state of nutrition. And there was, 1 year after the fracture, some attenuation of the decrease in the contralateral bone mineral density, femoral bone mineral density. But what was clinically important was the median length of stay in those patients in the rehabilitation unit was reduced by 33%. And since it was a double-blind trial, the patient nor the medical team was aware of the treatment, it seems that clearly by correcting malnutrition in this patient, there is some clinically relevant aspect of a reduction in the length of stay. And next slide, this could be explained by less complication. And this is a meta-analysis in the Cochrane database from 5 years ago. And what you can see that by giving some oral supplements in those patients with a hip fracture, it was possible to have less pressure sore, less infections, and overall there was a lower unfavorable outcome comprising both death and complication. And this was, once again, probably by hazard, 33% reduction. Now, next slide. Let's see what is the role of vitamin D deficiency and malnutrition, or vitamin D deficiency correction and improvement of malnutrition later on in the prevention of subsequent fracture. So in terms of vitamin D, next slide, we know that vitamin D alone is not very efficient in terms of prevention of fracture. We need to give both vitamin D and calcium. And on this slide, which is one of the most recent meta-analyses, what you can see is when you compare the risk of fracture in patients with receiving calcium and vitamin D versus placebo, no treatment, there is approximately a 6% reduction in the risk of any fracture. And when you look at the risk of the hip fracture, this is a 16% reduction, so 100 minus 84, a 16% reduction in the risk of hip fracture just by giving calcium and vitamin D. And this is particularly true in the oldest old and particularly true in those living in nursing homes. Next slide, please. Now, what about nutrition and what about dietary protein intake? And this is another meta-analysis with a follow-up of over several years, 16 randomized controlled trials, 13 cohorts, and observational studies. And what you can see here, that the higher protein intake comparing higher versus lower in some observational study was associated with 16% reduction in the risk of hip fracture. So giving back some protein to patients with a low protein intake can improve the outcome and reducing over the long term the risk of the fracture. Next slide. The question now is how much? And we know that there is an alteration of protein use in older people. When we are older, we are eating less protein. There is a phenomenon of anorexia of aging with a predominant sugar intake. Then we know that there's a reduced ability to use available protein. There's insulin resistance. The dietary, the absorption by the intestine probably is affected. And this particularly in those patients with a recent fracture, a greater need for protein, the inflammatory, the stress is contributing to some resistance to the protein intake, and aging as well is associated with resistance to dietary protein in terms of protein synthesis within the muscle. And altogether, this accounts for the loss of functionality detected in the oldest old, and this could concern muscle, bone, and the immune system. And based on this observation, the geriatrician now are recommending to increase the dietary intake of protein from 0.8 gram per kilogram of body weight, which is, as I said previously, the recommended dietary allowance, to 1.1 to 1.3 gram per kilogram of body weight, so approximately a 50% increase. But it's not easy in the oldest old to convince them to ingest more protein. Next slide. So a way to follow the regulation or the guidance we published 2 years ago, and this is a general recommendation for the management of patients with osteoporosis at risk of fracture. Nutrition is playing a major role, and we are recommending 800 to 1,000 milligrams of calcium a day, including protein with a value higher than 1 gram per kilogram of body weight. And this together with at least 800 units of vitamin D per day, in addition to daily weight-bearing physical activity, fall prevention measures, obviously. Next slide. But to try to reach this amount of protein, we should look at the servings portion as you want. And we know that 100 grams of meat is 20 grams of protein, 2 eggs, 20 grams of protein, and so on. And if you play with these servings and portions like you used to play with in the diabetes field, it's possible to increase and spread over the day the protein intake to reach this level of 1.1, 1.2, 1.3 grams per kilogram of body weight. So in conclusion, ladies and gentlemen, next slide, dear colleagues, the rule of a fracture liaison service is one fracture leads to another, and we should prevent absolutely this rule. And the prior fracture at any skeletal site doubles the future fracture risk. And the second fracture often happens within 6 to 8 months of the first one. And the aim today is to introduce this signal of stop by promoting a good vitamin D and promoting a good dietary intake, including at least enough protein. And with that, I thank you very much for your attention. Next slide, please. And I very much hope to meet you in London at the end of August for the World Congress on Osteoporosis. Thank you very much.
Thank you very much, Professor Rizali, for this excellent presentation. So just as a reminder, if you have any questions after this presentation, Professor Rizali will answer your questions at the end of the webinar. So we're going to now move on to our second speaker. Let me just present, I'm going to change my slideshow. Excellent. So now it's a pleasure to present our second speaker, Dr. Omar Al-Sayed. Dr. Omar Al-Sayed is an associate rheumatology consultant at the Rheumatology Division of the Hamad General Hospital, an operation of the Hamad Medical Corporation. Having graduated from Misr University of Science and Technology in Cairo, Egypt, Dr. Al-Sayed completed the Internal Medicine Residency Program and a Rheumatology Fellowship training at Hamad Medical Corporation. Dr. Al-Sayed is certified by the Internal Medicine Arab Board and is a member of the Royal College of Physicians in the United Kingdom. With a strong interest in research, he has initiated and received grants from the Medical Research Center of the Hamad Medical Corporation for many projects in the rheumatology and osteoporosis fields. Dr. Al-Sayed is also a member of the Osteoporosis Task Force in Qatar. I will now leave the floor to Dr. Omar Al-Sayed.
Thank you very much for this nice introduction, and thank you for IOF for this opportunity to present my slides here. It is about vitamin D status in Qatar. So it moved now, maybe let's try.
Yes, now it works.
Yeah, perfect. So the outline of my presentation, just we are going to talk about the recommended vitamin D level across primary and secondary centers in Qatar, and the vitamin D testing kit in our primary and tertiary centers, and also we are going to go through some local data regarding the prevalence of vitamin D deficiency and insufficiency in Qatar as well. Then we are using the following definitions of vitamin D level and the following cutoff in primary and tertiary centers. So vitamin D less than 20 nanogram per ml, which is equal to 15 nanomole per liter, is defined as deficiency, and 20 to 30 nanogram per ml, which is equal to 50 to 75, is defined as insufficiency, and more than 30, which is equivalent to more than 75 nanomole per liter, is defined in our lab as sufficient or optimum level. Then we are here in Qatar. We have two main labs who is running a vitamin D level, the 25 hydroxyvitamin D level, and all the primary healthcare centers and secondary and tertiary care centers are referring the test to these two main labs. Unfortunately, we have two kits in each lab. One is Roche and the other one is Beckman kit. Both labs are accredited by the College of American Pathologists, and they are under regular quality control almost 3 times per year. Then I will go through some local data here in Qatar and published studies. And I choose the most recent one and the most high quality one published data. So we have the first one. This study was published in 2012, and it was a systematic review. So it includes around 80 studies included in this systematic review, and the search was done from 1980 to 2012. Here they defined vitamin D insufficient or deficient was defined as a subject with a vitamin D less than 75. So they didn't go through different cutoff. So the authors of the study, they classify the cohort according to different age group, as you see here, less than 16 years and between 16 and 30 and more than 30. And also we have the overall estimate of the vitamin D prevalence, deficiency prevalence. It's almost, the overall estimate is 90% the prevalence of vitamin D deficiency / insufficiency, and people or patient who has less than 75 nanomole per liter. And as you see here, it's almost equal or comparable between different age group, between patient less than 16 and patient between 16 to 30 and more than 30. So the percentage of prevalence is ranging between 85 to 90. Then we have another study of vitamin D status among adults 18 to 65 attending primary healthcare centers in Qatar. It's a cross-sectional analysis of the electronic medical records from 2017 year. And this study was published in 2019. So in this study, they included only adult patients more than 18 years. And the total number of the cohort was around 100,000 subjects included in the analysis. And they defined the vitamin D level as severe vitamin D deficiency less than 10 nanogram per ml, and deficiency less than 20 nanogram per ml, and insufficiency less than 30 nanogram per ml. Again, they did subgroup analysis and they classified the patient at different age group. As you see here, between 18 to 29 and 30 to 39. And also they classified them to genders, male and female, and Qataris and other nationalities. So if we go for the prevalence of vitamin D insufficiency based on this study, which include good number of subjects, around 100,000. As you see here, it is almost ranging between 90 to 95 at different age group, and it's almost the same comparable between female and male, and also between Qataris and non-Qataris population. This regard is the vitamin D insufficiency. If we go for the severe vitamin deficiency, it is there is some difference between different age group. For example, between Qataris and non-Qataris, it is more prevalent in Qataris, the severe deficiency. It is 18.9 comparing to 12.3%. And it is also more in female. It is 16.7, while in male it is 9.7. And also it is more prevalent in young population. It is 26%. The nice of this study, they did subgroup analysis for patients who received vitamin D prescription therapy and who did vitamin D testing without receiving any vitamin D prescription therapy. So as you see here, the blue column is for the cohort who did vitamin D testing without vitamin D replacement prescription, and the orange one who did vitamin D testing and they received vitamin D therapy before the vitamin D testing. If we go for the severe deficiency, it is much less. The cohort who received vitamin D therapy, it is 3.3%, while who didn't receive vitamin D, it is 14.1. But if we go for the insufficiency, it's almost equal. As you see here, it is 87 and 92, which give us a signal that we need more effort to optimize vitamin D level in our population, as most of them, they are getting prescription, but still the vitamin D is still not at optimum level. If we compare our results to our neighbors in the GCC countries, so again, the prevalence also is almost equal or comparable. It is ranging from 80 to 86. But here maybe we need to mention that a different cutoff point was used in different country. But again, it is more or less it is close to each other. So to know our performance of vitamin D kit, so we did an internal audit just to test the PTH suppression at different vitamin D level intervals. So we know that this method, it is not well validated to see or to say this vitamin D level is enough or not, but it is very commonly used in clinical practice by physicians that they are optimizing or increasing vitamin D till they reach optimum suppression of PTH. So this is just an internal audit by reviewing analyzing the electronic medical records from 2017 till 2019, and we get around 554,000 vitamin D and PTH tests were processed from the same blood extraction. Then we excluded patients with chronic kidney disease and primary parathyroid disease, either hyper or hypoparathyroidism, and metastatic bone malignancies, and vitamin D toxicities. Pregnant ladies were all excluded from the analysis. So at the end, we end up with 19,000 sets of vitamin D and PTH tests were analyzed. So we run ANOVA analysis to see the mean of PTH suppression or level at different vitamin D levels, or vitamin D level intervals, and we make the vitamin D level interval less than 10, 11 to 15, 16 to 20, 21 to 15, and etc. till we reach to 46 and 50. And we compare the PTH level at vitamin D interval above 50 to PTH level at different vitamin D intervals. So as you see here from these tables, that the PTH suppression at less than 10 to PTH suppression to more than 50, the p-value is significant, and the p-value continue to be significant till we reach vitamin D level 26 to 30, started to be a little insignificant, and 31 to 35, it is insignificant, which means that once we reach vitamin D level around 30, the PTH will not be suppressed significantly, which is the standard level that used globally, that the optimal vitamin D it is around 30 or above. So we conclude from this internal audit that the optimum PTH suppression is observed at vitamin D 30 nanogram per ml and above. PTH will not be suppressed significantly more beyond vitamin D level of 30. So by this slide, I will finish my presentation, and this is my reference. And thank you for listening.
Thank you very much, Dr. Assed, for this excellent presentation. I will now move back to my screen here. Excellent. So now we're moving into the question and answer period of the presentation. So after these two excellent presentations, I will now read the questions that we've received from the participants. So just as a reminder, if you'd like to have your question asked, we have around 10 to 15 minutes to use the expert's time. And you can put your questions in the question box that appears on the dashboard of the GoToWebinar platform. So I'll begin with the first question. The first question comes from Dr. Yusuf Abdel Samad. The question, it can go either for Dr. Al-Said or Professor Rizali. The question is there a relationship between vitamin D deficiency and hip fractures in an adult person?
Okay, I could answer. The answer is yes. The lower the vitamin D level, the higher the risk of the fracture, in particular for hip fracture.
Excellent. Thank you, Professor Rizali. So I invite you to ask more questions. So far, we don't have another question. While we're waiting for everybody to write their questions in, oh, here we go. We have another one from Dr. Andrea Olascoaga. The question is, at my FLS, I can measure 25 hydroxyvitamin D. So I should, one, measure that in all fractured patients during hospitalization, and then supplement for 3 months before. So this question, before initiating treatment. So this question, it seems to be related to the procedure. So in the FLS, they can measure vitamin D levels. So it should be, the question is, should it be measured during hospitalization and then supplemented for 3 months before initiating treatment?
Okay, it's a very difficult question. It's based on several observations. The first one, vitamin D should be more or less normal when you introduce a bisphosphonate or denosumab. So this is a reason why the interlocutor is asking whether she or he should wait for 3 months. So the idea is to reach a relatively normal vitamin D status to give full efficacy to the bone resorption inhibitor. Now the question is, should we measure vitamin D level? If you can do it, it's always better. If there is some limit in the financial support, you should treat immediately with vitamin D, since we know that those patients are with a very high frequency, probably 9 out of 10, with some degree of vitamin D deficiency, so there's no risk to treat them. And the last question is, and this we don't have data, but just expert opinion, whether we should give one load of vitamin D before the daily, the weekly, or monthly administration. And here people are not totally agreeing, but probably if you want to speed up the repletion in vitamin D deficiency, if you give within the day after the fracture 100,000 units of vitamin D once, probably you don't take any risk, and this is likely to rapidly correct the vitamin D deficiency.
Thank you, Professor Rizali, and thank you, Dr. Olesquaga, for the question. So far, we don't have another question, but I'd like to ask a question actually based off of the end of your presentation, Professor Rizali. You were mentioning guidelines that you were saying should be implemented, for example, in terms of vitamin D and protein intake. With regards to protein intake, is there an age cutoff? Because you said that we should aim for higher intake than the RDA, aiming for around 1.1 to 1.3. Is there an age cutoff where this should be initiated?
Well, it depends on your own age. When you ask geriatrician what is the cutoff for an elderly, they said, well, above 75. But if you look at your relatives, maybe at the age of 60 already you are jumping or walking less rapidly as previously. And maybe the increase in protein intake should start by the age of 65, probably. Up to 65, a well-balanced diet is probably enough.
Okay, thank you very much for the answer. We have a follow-up from Dr. Olascoaga. mentioning that it's very interesting because they've been measuring all patients and over 80% have vitamin D deficiency. So treatment initiation in the FLS is taking longer for all the patients, not being able to respect the time on the KPI of initiating treatment before 3 months, 3 months since the fracture, for example. And they reinitiate or they reestablish that it was a very clear explanation, and they thank you again. So we have another question from Dr. Joanne Fagerstrom. The question is, in the JAMA article by Willett, 2005, where we think it's around 2005, he states that milk consumption is detrimental to health, including bone health. What is your opinion about dairy and bone health? He also states that yogurt is beneficial and is therefore the exception.
Okay, there is a lot of different meaning about dairy product and bone. My personal view is the following. The bone is happy with enough calcium, is happy with enough protein. And the easiest way to provide this enough amount is probably dairy product because it's relatively well tolerated. It's relatively cheap as compared with meat or other source of calcium. So for this reason, at the present time, dairy product, not as a treatment, but as ensuring the sufficient intake of calcium and protein is probably very, very positive. Now, there are at least 5 different meta-analyses over the last 3 years. And if you put everything together, none of these meta-analyses are concluding to some harmful effect of dairies. Some of them are concluding to a reduction in the risk of hip fracture, some to neutral effect, but none of them are concluding to some harmful effect. So at the present time, for me, the dairy products are relatively an easy way to fulfill the requirement of calcium and protein, at least up to the amount of 1.5 grams per kilogram of body weight, which is very difficult to reach. There is no reason to detect an increase in the risk of fracture. Now, regarding the fermented dairy products, here people are more agreeing, and it's probably based on 2 things. The first one, it's easier to have fermented dairy products as compared with milk in terms of tolerance. And second of all, fermented dairy products are providing some probiotics, and some have also some enrichment in prebiotics, and both of them are favorable for bone health. So in this case, fermented dairy products, including yogurt and cheese, are favorable for bone. And it seems also in terms of tolerance of cardiovascular risk, all the recent review and meta-analyses are concluding that there is no problem on the cardiovascular system with a normal amount of fermented dairy products like yogurt and cheese. Is it clear?
Thank you, Professor Rizali. We're waiting on the response from Dr. Fagerstrom right now. So if there's no follow-up to that question, I'd like to ask a question to Dr. Al-Sayed. You were mentioning in that vitamin D administration there that this is much below the level that it should be in Qatar, that the prescriptions never get followed up. So can you explain to us if any barriers or what kind of barriers exist with regards to vitamin D supplementation?
Thank you very much. I think there is many barriers for this. Most of the patients, they believe here in our area that vitamin D should be taken once a time and it's not a maintenance therapy. So this is one of the things that most of the people or most of the patients, they will say, I took it and then I didn't continue. This is one of the things that we need to improve our education to the patient. Another things, the vitamin D here, due to the weather conditions, you know that here the climate is very hot and the humidity very high. So most of the people here are hiding inside the homes, inside the cars, and even the cars are shaded. So the exposure to the sunlight also is very minimal comparing to the other areas. These are the two main things that I think that we need to improve, that the prescription and education of the patient, the importance of adherence to vitamin D taking.
Excellent. Thank you very much for the response. We have a follow-up from Dr. Fagerstrom saying, Dr. Willett also discussed the detrimental effects of D-galactose in milk. What are your thoughts?
Yes, not only Dr. Willett, but there is also the same issue treated by a group in Sweden. This group, with a large cohort of postmenopausal women and men, they concluded to some higher risk of fracture with milk, but with a lower risk of fracture with cheese and or yogurt. And to distinguish between these two sources, they ascribe the possibility, the difference in risk to maybe to galactose. I have no precise meaning at the present time. It's an hypothesis which should be tested, but I'm not sure that we have the definitive answer at the present time. But it's a nice hypothesis remaining to be tested.
Excellent. And with that, that will conclude the Q&A section of the presentation. So now I'd like to just, on behalf of IOF, thank everybody for your participation to this webinar, and we hope that you enjoyed the session. We'll publish the recording of this webinar on the IOF website, and you'll receive the link by email tomorrow. You'll be prompted to complete a brief survey immediately after this webinar, and we would really appreciate your input and comments as we continuously try to deliver webinars that meet your needs. If you have any question or comments, please don't hesitate to contact us by email at webinar@iofbonehealth.org. Before we conclude the presentation, I would like to thank our CTF sponsor for this webinar, who made this webinar possible. Thank you, Lily, for the support. And finally, I would like to thank Professor René Rizali and Dr. Omar Al-Said once more for their outstanding presentations, and thank you all again for your participation. So my name was Eric Brudet-Champagne. I'm the Capture the Fracture Coordinator at the International Osteoporosis Foundation. And with that, I would like to wish all of you a very pleasant evening and afternoon.
Thank you to everybody, and good night.
Thank you very much, and good night and good evening, everybody.